Good afternoon, ladies and gentlemen. Our webinar is beginning. I'm Steve Love, President and CEO of the Dallas-Fort Worth Hospital Council. We want to thank all of you for participating in this educational webinar, which is hosted in conjunction with the University of Texas Arlington College of Nursing and Health Innovation. They are an associate member of the council, which many other schools and universities are also associate members, and we really appreciate the collaboration with our schools and universities, and especially webinars like we're having today. The topic today is improving provider practice outcomes and the case for community-based data analysis so we have actionable results. Today, healthcare providers are becoming more aware of the impact that community characteristics have on the health. Obviously, we call it the social determinants of health, even health inequities. The trend for these community characteristics should be considered, obviously, when managing a patient's health care. Data is now becoming available that supports this effort, and it can really impact the outcomes of the patient and the provider measurements of outcomes. This presentation is aimed at demonstrating one way this can be accomplished. Today, our guests are Dr. Mary Tietze, a Myrna Pickard Endowed Professor at UT Arlington, and Dr. Charles Johnson, a Director of Academic Advising at UT Arlington. We're looking forward because we know this is going to be a fascinating presentation as we discuss the emergence of data analytics in healthcare services. Please remember, if you have questions, type them in the question box and we will try to do our best to answer them. In addition, for those of you wanting the CEU credit from this program, we will send out an email following the webinar, and you simply need to reply to that email so that you receive your certificate. With that, ladies and gentlemen, I'm turning this over to Dr. Mary Tietze. Mary?
So thank you, Mr. Love, for that awesome introduction and instructions for everybody as well. Thank you, Chris, for supporting our effort here to be here today with you providing this webinar. I also am grateful to the support I have from the University of Texas, Arlington, College of Nursing and Health Informatics, the education department there, and also the enrollment and student services department. In addition, there's another center that's very important with our being here today, and that is the Multi-Interprofessional Center for Health Informatics. My two colleagues there are Dr. Marion Ball and Dr. Gabriella Wilson, with whom I have the pleasure of working with every day to advance the health informatics workforce by the UTA students and faculty and our efforts with that. Finally, thank you so much for all my friends and faculty and the students who provided such a great outcome for being here at the presentation today. Dr. Charles Johnson will be presenting with me. I will be doing the initial parts of the slides, and he will follow up with our last objective. So this is why we're here today. We're here today because we want to help with the situation of those in poverty and those in need of support. To me, good data supports management of these complex patient needs. Here we have our some pictures from our book I love. It's called Dignity, and it is from Chris Arnade, who was a Wall Street broker interested in understanding poverty better. And in it, he identified what it was like to be in poverty and embedded himself with them. So these are just a few of the families and people that he met. But the bottom line is that he said they really are there with respect for themselves, and that we are there to help them only if we can find them and help them in the way that's culturally effective. As you can see here, we've got one family living from the car, and this is the one that the father said, when you don't have anything, respect is all you have. Poverty in this country is what is listed as, in 2020, the threshold of making $35 a day, living off of $35 a day. And we're not the only country that has poverty. We are one of many, and we have lots of work to do in that regard. The world has knowledge of poverty. The United Nations Sustainability Development Goals are an area that we have focused on too as a world. Look at that, 17 initiatives that sustain development goals throughout the world. Number 1, let's get no poverty. Number 2, zero hunger. Number 3, good health and well-being for all. Education for gender equality. These are, no-brainer, right? But the United Nations has given us a roadmap for allowing this to happen. So what does this have to do with healthcare workers? We are now, like Steve said, in the need of managing and finding those that are in need, that are underserved. They won't come to our doorstep. They're very proud people. They sometimes distrust the healthcare system and what we have to offer. So all of that has caused a new role for healthcare providers, and that is to increase our understanding of data, how to use data to find those who are underserved, and how to customize our interventions for those to those particular needs. So we're learning a lot about that. Hence, the discipline of health informatics evolves, right? In health informatics, you also have data scientists, you also have bioinformaticists, and so forth. Even the American Association of Colleges of Nursing has now identified information technology for the first time as one of the essentials of nursing practice. So we're in here too. And it's all about making data turn into information, turn into knowledge, and then into wisdom to improve the care delivery. Speaking of wisdom, there are a few sources that I believe touch on wisdom in this arena. One is Dr. Cooper from the Johns Hopkins University. She wrote the book, Why Are Health Disparities Everyone's Problems? Okay, it's not just they and we and them. It is everyone. And she gave a great different description of what it looks like, but also more importantly, how to train healthcare providers and others to address it. So that's in her book as well. Now, the other book here, Social Determinants of Health, in 1999, Marmot and Wilkinson wrote the first book on social determinants, and their main point was, sustained by scientific evidence, they held that differences in health between population groups are due to characteristics of society, not differences in healthcare. The first one, that's been evolved, and that's kind of like the almost not the Bible, but the beginning where massive amounts of data indicated what we have here in terms of social determinants. And then, lucky for us, in our own state, we have Dr. Cassell and Dr. Myth that have a blueprint for us, a playbook that actually tells you how to engage your community-based organizations to reach what you need to do for those that we've identified in need. So the objectives for today are to review some Texas healthcare-based data sites and their purpose, to identify community-based characteristics that impact health, explore geographic variabilities and variations, also looking at describing action-oriented interventions. And then Dr. Johnson will follow up with an overview of options for health informatics academic education, both undergraduate and graduate. Some of the main sources that support what I'm here to say is the CDC. They have a massive website that handles that and addresses all the social determinants of health interventions, actions, toolkits that you could need. The Healthy People 2030 report is very important with all the indicators that are available there. 358 scoreable objective indicators for us to work from. And then, of course, the healthdata.gov, my favorite place in the whole world, that has our tax dollars at work, information that's been collected from the U.S. Citizens through surveys, and then also through actual collection of physical parameters. So, healthcare data sites and their purpose. The two I'm going to focus on specifically are Texas Healthcare Information Collection and also healthynorthtexas.org. Just to give you the background, though, here's the healthdata.gov website, and there's a URL for you. And the area that I focus on is the recent databases and the database warehouse that they have. And some of the examples of those are Medicaid, chronic conditions, inpatient admissions, emergency department visits, and county by county. And they, again, it's them taking the information they have and turning it back to us as researchers and providers to mine that information and learn about our area. Asthma, emergency department visits. These are just some examples. There's plenty of COVID data sets and repositories there as well in terms of the hospital coverages and so forth. And then the Medicaid potentially preventable emergency visits. Those are some of the more common ones. So in this case, what we have is the Texas outpatient. Now write this down, PUDF, public use data file. Okay, that means that by HIPAA standards, it has been de-identified the cases. They're real cases that you're seeing, but the name, the exact location, you will get the zip code, and the more specifics of it, the patients are not indicated. So, but it is available for use on this particular website. So, an example of how do you get to that, okay? It's a flat file. There's no way I'm going to know what to do with it, okay, if I wanted to order it. So we use at UTA and to help with the providers is the ClickView Business Intelligence tool. And that allows us then through the Dallas-Fort Worth Hospital Council Foundation to give us a partial license. It allows then faculty and the students on a limited basis to learn how to access that warehouse and pull the files that are needed. As you can see, there's inpatient, outpatient, and quality databases. The one I'm going to focus on today is the outpatient database. So as you get to the outpatient database, you actually do some steps, and I have a 16-page step-by-step for the students and faculty on how they can get to this point where they're getting their data into an Excel spreadsheet. Everybody wants to get into an Excel spreadsheet so that you can do your own type of analysis with your own type of tools that you're comfortable with. So the data variables go like this. You get the quarter that you are just wanting. I've masked the hospital today, but you do have the hospital that was involved. You do have whether they're outpatient or inpatient. You have how they were admitted, physician's office, another facility, okay? How were they discharged? To home, to another care facility, okay? What are their age groups? We can't give you the exact age. That's part of the HIPAA binding, masking, if you will, for that data, so that you have a group of age. And that, 60 to 65 gives you a pretty good idea, 75 to 70. This particular data set that I pulled is for 60-year-olds and greater than. Of course, the gender, race, very important, and the ethnicity, as you can see on the second row of the data set. This is one continuous Excel spreadsheet. The county, and then important for me for geomapping is the zip code. In terms of, this is the zip code of the home address or where the patient lives, and not necessarily where the patient sought help in our hospitals, but we have that too if needed. The payer, very important there. Is it indemnity? Unknown is usually no payer, charity, if you will, as we used to also call it. So that's important into analysis. Then you have the principal diagnosis descriptions. In this particular case, I pulled all the the diagnoses relating to diabetes. Okay, so you have the foot ulcer, you have the cataracts, you have the ketoacidosis, kidney disease, and some examples that are relating to diabetes. The length of stay, of course, is going to be about a 1 because these are outpatient services, and that also does include the charge is incurred and sent along with the UB, universal bill, to the insurance company for that episode of care. And then whether they discharged alive or not alive, expired. Most of the patients here are alive. There's a 0. There's a 1 if they have died, and you see more of that in the inpatient data set. Okay, so those are the key variables, and we're very fortunate to have that. The hospitals work really hard to get their data cleaned, along with the Dallas-Fort Worth Hospital Council Foundation, to get that ready and sent to the State Department of Health in Austin. I was pointing out about that. Now, community-based characteristics that impact health. We call those the social determinants of health, also known as the social needs index in this particular case. And many, by the way, let me just say that many organizations do indicate that they are creating indexes, okay? It can be done by many, but people, data scientists, have an understanding of the weighting values and how to bring variables together. So you'll want to know about your index and how it was created, and also to observe it over time. So we're going to go in and look at some of them here. But before I do that, I want to explain a little bit about you're going to need to know at least this much about the social determinants. There are 5 categories in regard to that. They are healthcare access, neighborhoods, social and community context, economic stability, and education. In this particular case, there's some indicators over here that deal with the neighborhoods. And as you know, that social determinants are a condition in places where you live, where you learn, where you work, and where you play. That indicates your social determinants. And so an example here is, if you look at health policy. What's the health policy of the area that we're talking about here in terms of water systems? Okay, we see some of that going on in Mississippi right now. So what is the physical activity availability? How many walking sidewalks are? How many bike trails are there so that the population can be healthy in terms of their activities? How about respiratory disease and volume of asthma? What's the toxic level of the air quality in that particular zip code? And then another one is transportation. What mass transit goes in there? What is available to take the patients to their office visits? We're already finding out easily that is something that's in need. Okay, so those are examples of the indicators that lead to the neighborhoods and built environments. So an index that I will be using today is from the healthynorthtexas.org, healthynTexas.org. Write this down because it's free for everybody, and it has all kinds of ways of looking at it in terms of exploring the data, all the indicators that go on with various communities. So this is community-based information. Today I decided to go to Social Needs Index, and there are others. There's health equity. Those are the social needs and health equity are one and the same. Food insecurity is a different one, and mental health is a different index, okay? So let me talk about the health equity or the social needs. There are 6 indicators that make that up. The poverty level of the area, the income, the unemployment rates, occupation rates in terms of the areas and people that are living there, education, and language. Language as English second language or other aspects of it. Now, of those, they this index weighted the variables in terms of the indicator of the maximum, the correlation of the index with premature death. So if there was these indicators and premature death, it had a higher weight to indicate it was impacting healthcare. And then preventable hospitalization rates were also a weighting factor. So again, if you go there, it'll show you the details of how that was calculated. So what I have here is the zip code listings from top to 100 is the highest need on the far left. And then the ranking from, there's 5 different rankings. These are the top. And I just did this for Dallas and Tarrant County. Okay, so that's what you have there. 75216 was one that was particularly easy for me to designate to you on my Geo Map. The Geo Map is all the patients with diabetes. You remember that I showed you that spreadsheet in the Dallas and Tarrant counties. So it shows you the higher the blue, the higher the count, the darker the blue. Okay, so the 75216 is a high county for patients with diabetes. Now they're not connected yet. So what I do in the analysis is take the zip codes from the social needs index and that rating, and then associate with that particular zip code that has the patient with diabetes in it. So next steps being, first of all, looking at 75216, there's a massive amount of information based for each zip code that is available on our internet. Basically, 75216 is a median income of as you can see there, the 30,000, the income under, the number of incomes under 50,000, 71%. Those with, see the different ranges, and then those with the 100,000 is very small. Look at the race distribution, primarily Black, African American, and Hispanic. The rest are very small. Another indicator is the public school profile. In this particular zip code, the test score performance is below average. The percentage of students eligible for reduced lunches is almost everybody. And then the percentage of schools that are supported by Title I is 100%. So that means that they're getting subsidized for underprivileged children and to meet their challenges in state academic standards. So they're getting extra support by teachers and also resources. So again, a characteristic of that particular zip code. Now, taking that information forward, I'm thinking this index is looking like it makes sense to me. Here, what you do is, what I did was, and I show the students to do this, okay? Social index need per zip code, by zip code. So I take the actual zip code social needs index amount, remember 99.7, in this particular 99.2 for this particular zip code of 75210, and times the number of outpatient with diabetes in that zip code. So now you're getting volume of patients with diabetes and high need as that goes with all of them. So now I've got an index of 999.2 if it was 10, okay? And now that is what I'm looking at the Geo Map here. So the highest zip code there is 7,913, and the darker the blue, the higher the need. In this particular case, as you can, I don't have Dallas and Tarrant showing, but you can see if you look at Van Dam and then the Rains, and then the one next to that, the Dallas and Tarrant County are the ones with the darker blues in it. Now, we provide a lot of health care in Dallas and Tarrant County, okay? These are patients with diabetes who've sought health care in the clinics, okay? Through the rural area, there may be patients with diabetes that haven't entered the healthcare system yet. That's where the work is as well, is to understand that geography as well. Okay, so these are just to remind you too. Whoops, oh dear. Hate it when I do that. Going to This can also be a research file. One of my colleagues reminded me that we tend to work in the de-identified world when we're teaching, but as researchers, we can get the research file that shows us the more information about that patient, the patients we're looking at, the zip codes we're looking at. It also provides us with an APCD, which is, and we also have an all-payer claims data. What we're looking at here and what I'm showing you is administrative data. Okay, what happened? What was their diagnosis? How much did it cost? But when you start looking at things like the laboratory results or the laboratory claims, the pharmacy claims, you get a fuller picture of what it is that the needs are and the patients that we're looking at or the participants that we're looking at. It gives us more of a picture of the community when you get that. So there's more to be done, but a good place to start is in the de-identified data set. Another way to look at it, if you just want to look at the charges, which one of the zip codes was the highest charge for the social needs? So that's a difference, 75228, depends on what you want to look at there. And that should also be stratified by race, gender, primary care. Those all variables are available too. Another way to look at it here is the color provides the count. So the color of the darker the purple, the higher the number of patients that are in there of the diabetes. As you can see, the darker 194, the larger the circle is, the higher the charges. So it gives you a perspective, again, looking at what you might want to look at in terms of the care delivery next steps. You can also, to get this to the leadership, put it in dashboards pretty easily. And here I use the Tableau visual analytics tool to get it to this point. And this is something too that we teach in health informatics and to the students. Now we have everything there in one dashboard to talk about. So action-oriented interventions. Steve talked about that. There are those available. Generally speaking, importance here is that they are culturally sensitive. We're learning more and more how important that is. That there's community-based providers and navigators involved, and that there's community-based academic institutions involved. I think we're the last ones to come into the community, academics, and I'm trying to do that more and more. To remember, we have a lot of intelligent and free availability to help the community in this particular effort. So in the details of it, for the Geo Map of what I'm talking about here, realizing that culture is everything has been said by some of those that are working with this area of social determinants, that you partner with the community. It's called your CBO, and having that very active in where you reach. We're talking about the churches, we're talking about the senior community centers, we're talking about ways to get to the culture, the people in that area. You want to customize it, and there's plenty of outpatient measures to do that with, and then match those to what you're trying to get done. The word medicalize the CBO has also been used. That's where you actually put a little bit of your services, some of your services with the CBO as a partnership there, so that it doesn't look like you're the white Caucasian person coming from the highfalutin healthcare system, university system, that you are there with those that look like you and that you're providing the care with them. Pay attention to the provider workflow, very critical. We don't want to add more work to the providers in their effort to actually deal with social determinants of health. And the ones that have been most successful have actually integrated the use of social determinant characteristics and assessment into the workflow and making it pay off, to the point of actually helping them with their charges and the ICD codes that they're going to be using and their CPT codes. And then finally, monitor your index performance over time. Things change, okay? And that index that may have worked in terms of the mortality or in terms of the premature mortality may have actually increased some or decreased. So observe it, just like any type of analytics that you are watching how that's working for you. So what the objectives I said I was going to accomplish for you today were to review 2 Texas-based data sites and their purpose, to identify community-based characteristics that can impact health. I said I was going to explore geographic variations relating to Geo Maps, describe action-oriented interventions and actionable outcome results. And now we want to do another objective, and that is to do an overview of options that are available for health informatics academic education that is so needed, and it's a burgeoning field. And we're glad that UTA and the Multi-Interprofessional Center for Health Informatics are tied to the hip in getting this, Conhai and Mikey are tied to the hip in getting this done. So I will turn it over to my colleague, Dr. Charles Johnson, who's the Director of Office Enrollment and Student Services.
Great. Thank you so much for that information. It was wonderful. I learned, as always, from you a lot today. So, okay, let's go ahead and get into the next slide. So again, what program, the certificate we're offering right now in the graduate healthcare informatics, it's a health informatics, is an evolving discipline at the intersection of data science, health information, technology, health information management, and data analytics. So this certificate is designed for students who have earned a bachelor's degree in any discipline, aiming to enhance career with fundamental skills in health informatics. So this certificate is really great because it prepares the student to sit for the industry certifications, which are all right there. The ANA Informatics Nurse is great. All of them are great. So it prepares you to be able to sit for that certification. And in terms of the courses, it's 4 courses. You get your first one, the Principles of Healthcare Informatics, followed by Healthcare Data Management and Analytics. Number 3, Health Information Systems Management, which I'm a systems guy. I love this course. I took a little bit of it. And then that 4th, the Social Determinants of Health and Healthcare Informatics. Next slide. So for this webinar, we wanted to really just focus on the graduate certificate. I just want to put a little plug in here that we also do a undergrad one as well. And if anyone is interested, we will be doing a webinar in the future specifically on that one. But let's get back to why this certificate in the graduate one is so important. Is there's a lot of potential career roles. As we heard about, this is a really growing field. And so there are just a slice of what you can do with this certificate. Clinical Informatics Analyst Coordinator, Health Informatics Analyst Coordinator, EHR Documentation Specialist Technician. You also get that Health Outcomes Analyst Coordinator, Population Health Analyst Coordinator, Social Determinants of Health Analyst Coordinator, and Health Equity Research Manager. So you have a lot of opportunities that are really, we see some benefit of getting this certificate. So with that being said, if anybody is interested in learning more about how to enroll in this certification, I'm going to drop an email address in the chat, and go ahead and send me an email. We have a lot of dedicated staff that can answer any questions you may have on this, and we look forward to any of your questions that you may have.
Thank you, Dr. Johnson. And I'm glad you mentioned this. We have both undergraduate and graduate. And my colleagues, Dr. Gabriella Wilson, has the ability, she will be with us later on to talk about the undergraduate certificate as well.
Absolutely. Go ahead and put the email address in the chat now.
Okay, this is Steve, and Chris and I are monitoring the questions and the chat, and we certainly hope our participants will certainly put some questions in there. The first question that we have is, does UTA Informatics gather any advanced care planning, ACP, information? Or are you open to collaboration using ACP in a pilot project?
I love that. I think that is do you mind if I take that? One of my areas of not focus, but where I think are very needy, and this will help. It's a quality of life issue. And absolutely, there's my email right there. We are open to, we could put a module in there in one of the courses for that. And I'm sure Dr. Ball and Dr. Wilson would love to have that discussion too. I'm sure it's not the first time it's come around. So yes. I don't know if everybody knows what that means, but advanced care planning, it has to do with preparing yourself for those last years, the last phase, if you will, of your life. And I don't know, I don't think you can start that early enough. And I think it will help a lot with quality of life for those that are in those last stages.
Yeah, the next question we have is, can you cover how a researcher can obtain access to the research files that might allow linkage of additional health data or even clinical data?
Yeah, and I've got colleagues and I have done this numerous times. So if you're talking about the THCIC data set as an example, okay, but most sites are going to have an area where it says researchers or research data file. And on the THCIC website, you have an area that says research file. And there's a form you fill out that indicates what you need to demonstrate to them, convince them your argument of why you need that. So for example, schizophrenia, okay, that's going to be something that's masked a lot in the data. To do that kind of, and substance abuse, those kind of things. I don't know if I'm using the exact politically correct word, but then you're going to need to have the research file to do that. And again, if you want to, you can justify it, you can write it out. It shouldn't cost. They want us to do that. And then of course you'd have to demonstrate that you've gone through the IRB or will go through the IRB at your institution to protect the data and those involved in the participation.
The next question or comment that came from one of the participants, I listened to a podcast, HBR, Managing the Future of Work in the HR IT presenter talked about data analytics as an open field and would advise individuals to seek out training and education in that field. So I don't think that's really a question, but a comment that supports what you and Charles have been saying.
Yes, and I like what that question is about, because they're talking about the analytics aspect of health data. There's more than that. As you can see in the list of what Dr. Johnson put it in terms of list, you can be an electronic health record specialist. You know why? Because if you don't have good workflow for the provider using that electronic health record, data garbage in, garbage out. Okay, what we're trying to do is get that workflow managed so that it is part of the clinical flow of the patient. And that's what I was talking to of the provider. Same thing goes with when you add social determinants of health as an assessment. It can't be something extra. There's too much extra. So that's another aspect of health informatics is the technology side of it. Yes, analytics, very much needed. And there's a whole list of types of it. You've got everyone from your data scientist to your clinical informaticists to your analyst, pure analyst, kind of on the lowest rung of the ladder. But everybody's got a place to do that. The third part about health informatics, if you don't mind me saying so, is clinical decision support. That is a specialty in and of itself. It borderlines in needing artificial intelligence as part of it, but it's basically algorithms that if you see this happen and this happen at the same time, then you probably need to notify this provider that this has happened. And it happens in the background, and the electronic health record takes that, but it takes programming and understanding of clinical decision support to do that.
And I would just add that as we navigate year over year, AI is going to be more adapted into these sort of operations where it really is all about data analytics and all of these things we discussed today. It's just going to start becoming part of these workflows. So just a tremendous amount of opportunity already and also coming down in the future.
The next question is, There is much going on with public health information. We've identified gaps, obviously, that we saw during the pandemic. Are these types of data being used with new public health informatics curriculum that's being developed under the ONC curriculum development grants?
I'll take that one. That you can follow up, Dr. Johnson. Basically, our federal government recognized what happened in the pandemic and the gaps that you talked about. And right out of the chute, dollars became available to universities and academic centers to start a discipline called public health informatics. It was probably underway, but obviously not enough. So yes, UTA, University of Texas at Arlington, several of the universities throughout the state of Texas are actively putting together the curriculum supported by this fund, and also supporting the students and free internships, that kind of thing. We're trying to funnel in students to not only be public health, but be public health informatics. And those go hand in hand. So yes, it's happening. Thank goodness. Hopefully we'll be better prepared if we have it again.
The next question is, does the certificate program provide technical training with SQL, Biostats, and other analytical tools?
Okay, love that. So I tend to be a GUI, graphic user interface type person. If I'm forced, I'll do SQL, okay? But health informaticists generally use tools, okay? Now, it doesn't mean we don't teach that. So they're introduced to it to answer your question, but they do not become SQL programmers, okay? They are health focused and tool focused, if you will, what I did today, and working hand in hand with providers. I'll ask Dr. Johnson if he wants to add anything more to that, but as it is right now in the certificate, there may be some that are more heavy into those kind of programs, and they can be an add-on. I recommend that to the students, that those are available as an add-on to the health informatics basics. Dr. Johnson?
Yeah, I would agree with that statement. There are some add-ons where it's going to be really heavy in the coding aspect of it and other sort of machine learning elements, but this one is not really heavily focused on those. But there's tremendous sort of supplemental opportunities that you can get for free that will, have that synergy of what you're learning in this certificate, right? Coursera, YouTube, there's a lot of really just awesome free source things out there that really go well with this curriculum as is.
I love that question, because really it's a marriage between the health informaticist with clinical background or health background, but not heavy duty data science programming. And when I get into a project, I'm okay, where's the data scientist? Where are my programmers? Because those are the people I'm going to work with to make the thing happen that needs to happen. And so, yeah, there's more of a collaborative activity that I'm used to seeing in that regard for right now.
The next question is really addressed to faculty, and it says, as faculty, can you briefly describe how you teach analytic skills and competencies?
I'll take that. Okay. So since I do that, and have done it for, years and years, 15 at least, very carefully, okay? What you want to do is make it a win-win for them. Most people coming in that are, especially healthcare background, unless they're, highly technical to begin with, coming out of ICU or emergency department, they tend to have that technology bent. But otherwise, you basically are walking them through small parts of technology first. Excel, they get pivot tables. Oh, Tableau, yes, here's how you do that. So you're going down the pathway. In our program, we have probably 20 tools by the time all said and done, and they see them over and over after time. And that's what it takes using it. And I have what I call step by step So we actually go, here's what you do, click here, this is the picture you should see, click here, this is what happens. And then eventually they're doing it on their own and very bored if I try to make them do a step-by-step at that point. So I would say very carefully, and that you want to make it a win-win, that they feel comfortable and happy about their connection of their understanding of healthcare and what the data can do for them. That's the important thing.
Here's another question by someone doing research. When you look at the data at healthdata.gov, is there a specific way to identify sex, not only race? And the reason I'm asking the question, I'm currently looking at a specific zip code in Dallas, looking at obesity in African American women and how this is impacted by the social drivers of health, i.e., not safe places to walk, exercise, etc.
So see, are they saying that the sex matters? Is that they're just trying to identify the females?
African American women. They're trying to identify females. So the question is sex available in the data?
Yes, it is. I think the spreadsheet I didn't point it out, but it has sex MF or U. MF, male, female, unknown. Okay. I thought you were going to ask me something about gender identity. That database doesn't handle gender identity. Okay. Well at all. You're going to have to go to another data set, a repository for that, but it'll have a male. You'll identify your females, your birth females, whatever you want to call it, males, and then those with unknown are usually those that are in transition or not wanting to divulge. So yes, the answer is yes.
Here's a comment, just so all of you know. Children's Health put this comment out. We're working on a large social determinant of health initiative. If you have interested students who need rotations, we welcome it.
Who was that? Children's Health?
Children's Health.
Okay, I have colleagues over there. Good to know. Absolutely. This is where we have as part of our program is community service. It's not necessarily a practicum necessarily, but just doing something for the community. And we have data analytics and those kind of skills that we can share for free. And we would love to learn and be at the elbow with that particular team. So thank you, Children's Health.
Here's a question, and I hope I'm reading this correctly. How about a postgraduate certificate, postdoctoral? Does UTA provide that?
I'm going to let Dr. Johnson follow up with this, but for the graduate certificate is a master's certificate, right? So that you've got something, like he said, you've got a degree in something at the bachelor's level, and now you're in the graduate school getting a graduate certificate. The answer to the doctorate is a yes, no. Okay, so you can actually take what you have as your focus of informatics at the graduate level and use 6,000 level courses and create the doctorate. We don't necessarily have something that's called a doctorate. We have many doctorates throughout the university, but in terms of you can actually use that as your base and then do your focus on informatics to get the PhD. Dr. Johnson?
Yeah, I would say, specifically what we're looking at right now, and we talked about, was the graduate certificate in healthcare informatics. And so as we sort of, move forward on all these initiatives, these are all things we will explore and keep everybody abreast of what we're going to be coming out with. But this is going to be specifically the graduate certificate in healthcare informatics.
To follow up on what he said, there is a way to do your focus from the College of Nursing Health Informatics, for example, or some of the other disciplines, and then take your focus to be a health informatics by taking some additional elective courses.
Yeah, additional courses, and you can email me specifics, and we can reach out with you some more information. That we
would love to do the creative thinking to get that going. Definitely.
Absolutely.
The next question is, Are you collaborating with the University of Texas Arlington Computer Science and Engineering Department with people such as Dr. Ahmad?
I would say that through Dr. Marion Ball, Dr. Gabriella Wilson, they're the connection for ConHI, College of Nursing and Health Informatics, which is what I'm the affiliate for nursing to that center. And that center has engineers, Dr. Hamid, those are all there. Steve, if you could give me the spelling of that, I can definitely reach out. We have had a collaboration with the computer science department. So I don't know if it's specifically with that particular person.
Okay, we'll get the name. The last name is A-H-M-A-D, Dr. Ahmad. First name is I-S-H-F-A-Q.
Okay.
Okay, here's the next question. I'm doing my master's in health informatics. However, my last study background was biology. Currently, my syllabus does have SQL, and I like it, but my question is, what will be a good choice of another tool instead of SQL for a beginner?
Python, Dr. Johnson, did I select the right one?
So my background is in actually educational technology, and I would say absolutely Python for two reasons. Python is really going to help you in a lot of things you're not even wanting to be helped with. It's a smart platform. It's open source. There are so many resources to learn that as well. So yes, I would agree with that statement. Python is probably going to be that best source.
Then that would R be the next R?
Yeah, so R is great as well because R is open source. I actually did all of my dissertation statistics in R. There's a learning curve on the beginning of R, but once you kind of understand it with any programming language and you use it, it becomes logical, right? It starts to make sense. R is fantastic. It's really, I look at it like this: old school's SPSS. R is kind of the new wave of thinking in terms of statistics in that format. And again, with it being open source, there's just a tremendous amount of free resources to learn. And I would challenge anybody that's wanting to get in that space to look up some of those free courses. There's free data sets. It's really great. Python, R would be really good for your tool set.
Thank you.
In our courses, by the way, to that person who asked the question, I do have SQL in there, and it's taught by LinkedIn. Okay, yeah. So it's an awesome, they're wonderful LinkedIn programs that actually walk the students through that so that they have an understanding. Now, they don't leave being a programmer, but they have a good understanding of what it is.
Here's another question. You mentioned filing data with the state called THCIC. Who can get access to the THCIC data, and how do they do it?
So, two things, okay. Our Texas State Department of Health has an income source related to the THCIC data set. So there are some in the private sector that actually pay for that data, the de-identified version that I showed you today, okay? That's one aspect of it. That's probably not what you're talking about, but there are companies that buy it and use it that way. Healthgrades.com is an example of that. There are other companies. The second aspect is being a university, and this is where myself and my colleagues in teaching, they actually in the legislative act, Health Code Act, says universities may access it for no charge. Okay, no charge. So at the no charge level, we get a flat file. There's nothing that they help us with getting to the data. They just send us, we have access to the flat file, not that they send it. So we have to manage that. So in our case, like I said in my presentation, I partner with the Dallas-Fort Worth Hospital Council Foundation that they provide me the GUI interface through a business intelligence tool, ClickView, and then I can just drag and drop. I want this quarters, I want this diagnosis, I want this age range, poof, I've got a Excel spreadsheet with 300,000 rows in it to work with. So that is the answer. I think those are the two ways. It's in a private sector accessing it, or university, or as a researcher. Because remember, the third part is if you're a researcher, you can add and you can justify use of it. They'll go to the research file and fill out that form. So there's a third way.
Here's another question. You referenced the Healthy North Texas website. What other Healthy North Texas social determinants of health indexes are there, and how are they calculated?
Yeah, so I said myself, for you to understand your indexes, right? So the health equity and the social determinants, social needs are one and the same. And those particular ones, they actually, Healthy North Texas partners with something called Claritas.com. Claritas.com is a company that gathers consumer information, consumer behavior, consumer health, consumer locations, consumer devices they like to use, etc. And so from that, they utilize the 6 indicators that I put on the screen, on the slide, that actually said the income, occupancy, education. So those are from Claritas.com. In terms of the food insecurity is another index. And that again is from the Claritas, but they also take into account areas that have used the SNAP. That stands for Supplemental Nutritional Assessment Program, SNAP. So if you're using SNAP, it's because you're in a food insecure situation. So that becomes another variable that they add to their food insecurity index. So again, it's all on the site in terms of getting to that. And then other characteristics there. The third one for mental health is very uniquely different. For mental health, their self-reported poor health status is something that they collect, but they also utilize our tax dollars at work, the American Community Service, the American Community Survey. And that's one of the ones that we ask thousands of Americans, questions about their behavior specific to mental health and some of the other applicable indications for that. And they also use the CDC Places Project. So those are the 3 indexes, and then generally, and I'm sure that they will talk more than happy to talk more about that if you were using it and wanted to get more information.
We have time for one more question, and we have a final question. So this is really timed out nicely. You've presented this and we're looking at it, but what outcomes can you share that have really been realized using this community-based analysis? So,
I can teach people, how to do this and how to get their outcomes. I'll let Dr. Johnson come over, but specifically, I want to give you an example. There's an entity called the Health Equity Health System in Arizona, just as an example, okay? And they've completely got social determinants throughout their assessment and their program and for the providers using it and so forth. But in this particular case, there's an aspect of it where one study evaluated, this is their quote, the impact that providing medical respite home housing, so respite housing, to people experiencing homelessness, okay, in Connecticut, another area of their system, had on readmissions. And the readmissions were able to be reduced for the homeless patients by 6 to 14% over 3 years, with an estimated savings of $12,000 in patient across all Medicaid claims in the years following the study. So that's kind of low-hanging fruit. If you do preventive care, to those who need it. They will not be at your doorstep in the emergency department or readmitting. So that's just one way. That there's others that are more specific. That's just one of the bigger ones I wanted to share with you as an example.
Charles, did you have anything to add?
No, sir. I think that is the great thing about this. There's so many different pathways, and it's all important. And that was a really great way to end this webinar.
I want to thank all the people that participated and stayed with us for this hour. And we certainly want to extend our thanks to Dr. Mary Tietze and Dr. Charles Johnson for an excellent presentation. And I want to thank the great questions that we received. Excellent questions. Chris will post this tomorrow, probably in its entirety on the website. As I indicated earlier, we'll coordinate with you related to the educational credits that you'll get related to CEUs. But on behalf of our guest from the University of Texas, Arlington, and the Dallas-Fort Worth Hospital Council, and this really touched on a lot of the great work we're doing in our foundation here at the Hospital Council. We want to thank you for your participation, and we hope you have a great remainder of the afternoon. Thank you.
Thank you. Thanks, students.